about the state of ALS research and clinical trials and where we're going, based on a meeting that we had last week in Philadelphia, the American Academy of Neurology. So when someone gets ALS, they worry, well, what's wrong with me? What will happen to me? What can you do to help me? And these three questions immediately lead to considerations regarding diagnosis. Many people in this room have been through this. What is going on? Could there be other things that we could try to fix? What's the prognosis? What are the potential treatments? And we'll go through that quickly today. What are the alternative causes? What are the prognostic factors? What are the available treatments? Now this is a timeline. Does this have a, yeah. This is a timeline of the development of progress in ALS in terms of developing things we can measure, developing the first treatment, Riluzole, looking at trying to define the rules for doing clinical trials and developing new treatments, and where we are up into the 2000s when the next drug beyond Riluzole was Nuedexta, and still after over 50 clinical trials, we still haven't gotten another disease-modifying treatment. And that's what I want to talk to you about today. Many years ago, we felt that we needed criteria for defining the disease process. This led to a conference that helped establish the ALS Association and the MDA in Spain. Stephen Hawking's wife opened that symposium. We outlined the criteria for the diagnosis of ALS, and then at a second conference later on that year, reviewed that criteria, got further input from people. And this is the criteria that we use now for looking at epidemiological studies. There was a refinement of these criteria after we had this conference on guidelines for how to develop clinical trials. In over 20 years, there haven't been a new set of guidelines. We just finished a paper that we submitted to Lancet Neurology, and if they accept it, it will be the first step for a new kind of clinical trial calculus. That calculus, we're going to say, has to involve looking at different types of ALS and stratifying between treatment and control at each type of ALS. Defining whether there's widespread denervation on the EMG. You've all had EMGs, you don't like it, I'm sure. But how much acute denervation is present at the time that the treatment starts is a defining factor of how well the treatment may work. And the third most important point that we made in this paper that we submitted, we have to have longer clinical trials. Why longer clinical trials? One reason is that 20 years ago, in 18 months after randomization to a treatment or a control, 60 to 70% of the people will die. Now, in the recent clinical trials, only 25 to 30% of the people will die in 18 months. So something has happened to improve the care of ALS patients. You're going to hear about that today. It will be very close attention to nursing care that Ms. Lucas will talk about, very close attention to assistive devices, which Ms. Ward will talk about, very close attention to nutrition, which Mr. Fisher will talk about. A recent clinical trial showed there was a significant effect of gastrostomy in the survival in ALS patients. And Ms. Langford will be talking about the role of respiratory interventions. All of those have led to this new change in the last 20 years, and that's why we feel we need to do longer clinical trials. We simplified the diagnostic criteria in 1998, and there will be a meeting in 2 weeks in Brussels looking over this criteria once again. We defined the ALS functional rating scale. This has become the standard way that we monitor people, and this has become a clinical trial outcome measure. Professor Sanjak, who was on one of these papers, maybe you can see him, is that his name? Right there. He's developing a new component of this, which will be standardized here. You'll probably hear more about it as we talk to you in the clinic about it. So we needed to have precise diagnosis to define the proper treatment. We talk about flail arm or Bernhardt type of ALS. You'll also hear about BAD disease. That's a slower variant of ALS. The leg predominant Pertica syndrome is another slow pattern of ALS. We feel that all of these components have to be defined at the time that people go into clinical trials. And then if you have a slowly progressive disease or a fast progressive disease, then you will be compared to a control within each type of ALS. But what treatments do we choose? We have to look at particular treatment targets. We talk about different ways that the nervous system may be involved in terms of dying back from inside, whether there is damage to the muscle that affects the nerve, whether there are attacks on the mitochondria. All of these things have been what we've been looking at in the past 50 years. And today I'm going to tell you, based on a meeting that we had last Friday, what is the newest concept and how it's going to change our therapy going forward. So we have looked at excitotoxicity, and that led to the development of a treatment called riluzole. And riluzole has a definite effect. It's present in 4 studies. I'll go into that in more detail. But basically, it does work. It's just not a strong treatment. We're trying to figure out why it isn't a strong treatment, how to make it a stronger treatment. And work is ongoing now at the University of North Carolina in the biochemistry laboratory with our group. And we just recently talked to some people at Wake Forest who have been looking at how to enhance the effect of this medication. So it is a good medication, it's just not a strong medication. We have to work in that regard. We think that the effect of riluzole may be on the release of glutamate. Other people think it may be on the uptake of glutamate. And so if there's controversy among scientists on what's going on, you can see why it's difficult to develop new treatments. Some people feel that mitochondria should be made healthier, and this has led to evaluation of creatine and coenzyme Q10. In high doses, this doesn't seem to work. It may have some positive effects in terms of training paradigms, but not in terms of a disease paradigm. Whether a cell will die according to a particular program that's inherent in the cell, which is called apoptosis, which means that your hair will fall out when you're at a certain age. Then they've looked at several drugs along the line of this, and that does not seem to work with the drugs that they used. They've looked at antioxidants, and there's a whole slew of things. The most well-studied is N-acetylcysteine. We've looked at neurotrophic factors to see if we can make the nerves grow out better. And they haven't worked. Growth hormone, insulin-like growth factor 1, ciliary neurotrophic factor, brain-derived neurotrophic factor, glial-derived neurotrophic factor. This is the legacy of the decade of the brain in the 1990s. We thought if we could throw a neurotrophic factor at ALS, it would make it better. It didn't. So we're looking now at autoimmunity and innate immunity. There were some trials of NP001 from Neuraltis, and then other things looking at the immune system. Recently, we've identified that there may be what is called ALS-LAUS, laboratory abnormality unknown significance, and that may be the group that should have an immune treatment factor going on as well. We can look at the effects of drug on strength, the effect on survival, the effect on function, and the effect on quality of life. These would be things that we can measure or ask the patient. If we look at those clinical trials that have looked at strength, like the recent one, tirasemtiv, telampanyl, celecoxib, topiramate, the growth factors, creatine, they didn't seem, and insulin-like growth factor 1, they didn't seem to have an effect. If we looked at those treatments that are on survival that might be disease-modifying drug treatments, this is a diabetes drug, this is a depression drug, anti-epilepsy, a multiple sclerosis drug, a Raynaud's disease drug. The only one that played through on survival was riluzole. If we look on those with respect to function, lithium, and function would be measured by the ALS functional rating scale. Then we have lithium, coenzyme Q10, THC 346, an anti-AIDS drug, and insulin-like growth factor. They did not seem to play through. If we look more overall at all of the endpoints, some of the drugs had no effect on survival or function compared to placebo. Some actually made survival worse and function worse than placebo. Some actually made function worse but didn't have an effect on survival. Some made survival worse and didn't have an effect on function. So this is why we do clinical trials. The hypothesis may be that both function and survival may be improved, but sometimes that doesn't occur. In terms of symptomatic therapies on strength, guanidine, 3-aminopyridine, theophylline, tirasemtiv. Tirasemtiv is still going to be looked at because it had an effect on strength and vital capacity, but these others have only small effects on strength. Pseudobulbar affect is treated significantly by Nuedexta. There are new clinical trials looking at whether that helps speech and swallowing. And then we use botulinum toxin for the treatment of sialorrhea or increased saliva. And there are 3 clinical trials that show that that is a good add-on treatment. This shows you the papers that have come out in the literature since the development of riluzole and the number of trials that have been going on. These are those 3 young musketeers in France when they developed it in the early 90s. And these are their most recent pictures. They're not young anymore. This is sort of an interesting story on itself. It started out with a small company that was working with a Russian pharmaceutical company. It joined to create a bigger company, and then it became an even bigger company, and then it was bought up by an even bigger company. Today in the Charlotte Observer, we heard that one of our local drug companies was bought up by a Danish pharmaceutical company. So it's still happening, even in Charlotte. I want to go a little bit in terms of how we look at riluzole, which is the most important disease-modifying agent in ALS because it's the only one that we have. There are several studies that support the use of this. And I want to show you the kind of evidence. We look at what was called a forest plot. We call it a forest plot because it looks like trees in a forest. And so if you look at the bottom here, we can look at whether there's a treatment effect one way or the other better. Going this way favors the control. Going this way favors the treatment. If we look at the line of no effect, that means there's no difference between the placebo treatment and the patients. If we look at the direction of the effect, that's what I just covered a moment ago. And if we look at the estimated confidence, the confidence is, this is like the median and this is the plus or minus standard deviation or 95% confidence limit with respect to that. And then you have, these are the individual studies up here, and then the analysis for the whole set of studies is called the meta-analysis evaluation. In a meeting. If we look at the survival benefit of riluzole, you can see that the first study in 1994 showed an effect. This was, again, repeated in a second study. In the 2002 study, those included patients who were not allowed into the 1994 study because they had disease too long. And what that showed was that if you have had the disease too long, there is less likelihood of getting the effect of riluzole, and therefore you should start riluzole as early as possible. But even including all of the studies, there was a significant effect on survival. Now, if we go to strength, what people have said is it doesn't seem to make me strong. That's why we wanted to look at medicines like tarasemtiv and some other medicines to make people strong. And you can see here, in the first study, there was a suggestion of strength. In the larger study, we did not confirm that. In the follow-up study, we did not confirm that. So the overall analysis is, across a large group of patients, we do not see an effect on strength. How about bulbar function? This was one of the most important things that sort of came out of this, is that in the first study, not much, but a suggestion, and then the other studies showed that there may be benefit, and the combined effect showed a small effect on bulbar, that's speech and swallowing. And then on limb function, measured by a scale, again, there is a small significant effect. So the treatment effects of riluzole are not large, but they are robust. You can see them again and again in different studies, and they're durable because they persist over the length of the study. The medicine, dexpramipexole, zaloprodin, which was another French drug, and lithium, we looked at the combined endpoint on survival with function, which was a new way of looking at endpoints. And these, unfortunately, did not play through, including the dexpramipexole study. Am I stuck there? Okay. So, many people ask about what is the future. People have heard about brainstorm. This is the idea that you can take cells from your bone marrow and, similar to what they can do for leukemias, create stem cells that then might help replace cells within the nervous system or help cells to prevent them from dying. So I wanted to talk about this because this is now in a very primitive development stage. The idea is that ALS, of course, is a serious disease, and you'd like to replace the cells within the nervous system just as we could replace some cells in the bone marrow in people with leukemias. And the idea here is you would take cells from a person's own bone marrow, take them out of the bone marrow, and then create different kinds of stem cells. The ones we want to create are neurons. And this has been done over 40 years for a number of hematological diseases, so we know it can be done. The idea is that you would take the bone marrow, isolate, expand the stem cells that you isolate, differentiate them into neurons, and then put them back into the person. These studies have already been ongoing in Italy, Turkey, the United States, Germany, other European countries as well. We're beginning to get the safety and the engineering things sorted out of getting the cells in. The problem is that none of the cells, once in the spinal cord or in other parts of the brain, have sent out processes to the muscles. So we're hitting a roadblock there in particular with respect to these concerns. And that is a big problem and leading to a lot of scientific effort in that regard. The issue here is you can see that, this company that is saying it's a good thing is trying to define it as a business, and they're trying to sell to different hospitals the capability of making these neurons. Right now, at the Carolinas Medical Center, we're making stem cells from bone marrow, but only for hematological patients, leukemia patients and things like that, for bone marrow transplants. So the technology is in place. The question is whether the technology should be used at this point in many hospitals. To answer that question, there's a study at Emory, there's going to be another study ongoing at Cedars-Sinai in Los Angeles using a different kind of stem cell that you keep in a freezer, and then you open up those stem cells, and they're embryonic fetal stem cells. And they have a good track record in terms of safety, but again, hit the same type of roadblock in terms of not sending out the extension to the muscle. The science has reached the point now where we're beginning to realize that if we put the stem cell into the muscle and the spinal cord at the same time, that will begin to make the cells in the spinal cord want to reach out to that muscle. And so what's happening now is scientists are trying to figure out what is the signal that is being sent from the muscle when you put the stem cell in the muscle to make it want to come out into the muscle from the spinal cord. I believe that that is similar to like the first 100 feet of Wilbur Wright over there in North Carolina when, I think 1904, flew 100 feet and then a mile, and then by World War I we had the planes going like crazy. So I think we're almost over that roadblock, but it's still going to take some time to get there. And then the question would be, if we can get the cells down to the muscle, will they re-innervate appropriately to the right muscles? If you cut a nerve in the face or have Bell's palsy, sometimes the nerves go to the wrong muscle. So we still have problems ahead of us that at the bioengineering level we have to solve. This shows you how the brainstorm people are thinking of this as a business model. So it's not an altruistic science concept, straight up. The new way that we're going to be looking at ALS, I want to share with you, based on the meeting we had last Friday. And this was based on the fact that ALS, similar to Alzheimer's disease and similar to Parkinson's disease, may be a disease where there is abnormal protein in the neuron, and that abnormal protein is damaging the neuron, and if we can get rid of that abnormal protein, then we may be able to delay the progression of the disease even further. And I'll tell you what's been shown in Alzheimer's disease that leads me to think that we may be headed in the right direction, and then what's going to be developed in ALS as we move forward. If we look at all ALS, we see 1 to 2 per 100,000, 85% of it's sporadic, and 10 to 15% of it is inherited or familial. Among the familial cases, greater than 90% of those are autosomal dominant. Then there are rare genes as well. The alsin gene, the ALS4 gene, hexosaminidase in young people, and then this gene, which we reported 2 years ago with the Northwestern group. The most important aspect about this gene is it's a garbage gene. It says that there's a problem in cleaning up the protein within neurons, and that has led many people to begin to look at this hypothesis of garbage being collected in the neuron and is not being able to be picked up at the curb every week. So if we look at sporadic ALS, some of the genes that are in genetic ALS may occur low frequency in sporadic ALS patients. And so we don't know whether, one theory is that sporadic ALS might be just by luck. People may have 1 or 2 or 3 of the rare genes that in them, and so that some of the sporadic cases may actually be genetic cases. But we think, based on the work from the Veterans Administration, the fact that veterans have a higher rate of developing ALS, that there's definitely an environmental factor going on here. So the question is, can we learn something from how ALS spreads? Both sporadic and autosomal dominant disease, you're normal until disease onset. The disease may be earlier in the course of your lifetime if you have a mutation. I've seen patients who've had symptoms of ALS in their teens and their adult years, but they live to be 65. So, you know, having the symptoms, if it goes slowly, is a whole different picture than having the symptoms if it goes faster. Mutations do disrupt protein structure, and we've identified that there are protein aggregates that may contain particular proteins. In ALS, that's the SOD gene. And when you take these protein aggregates in Alzheimer's disease, protein aggregates which are called amyloid and tau, Parkinson's disease, alpha-synuclein, and SOD mutated proteins, and put them onto cells in culture, they act like poisons, and so too much can be bad. And so maybe it would be important to get rid of it. This statement means that whether they become abnormal aggregates or clumps is a function of what kind of protein it is, if it's mutated, whether it may be damaged by trauma. The TDP43 protein may be induced by injury to the nerve and then go back into the spinal cord. And then there's this issue of propagation from the site of where it starts. So if it starts on one side, it may go up and down on that side, and the spread of the disease may be contiguous, which means it goes from cell to cell. There are alternative theories going on here, but the contiguous spread theory is consistent with what we call a prion-like disorder, which means an abnormal protein may be making other cells develop abnormal proteins. What this will mean is that the collection of these abnormal proteins misfolding will cause cell death, and then if they're released, they may cause cell death after spreading from one cell to the other. We can reproduce this for SOD. This is a friend of mine who worked in Canada, showing that they can reproduce the same thing in culture. And I think this shows you that the dying motor neurons have these clumps of this abnormal protein. The first observation of this was back in 1970 in Toronto, and people couldn't figure out why it occurred. In many of our animal models, independent of SOD mutants, we can produce an increase in these abnormal aggregates, and they can occur within the brainstem or the spinal cord or different other parts of the nervous system. This is a molecular structure of one of those aggregates, and if you look at mice that contain the gene and make them have more aggregates, then they have a faster disease. Now you're seeing here the name Biogen IDEC, and you're seeing here the University of British Columbia. Research has been going on now in Alzheimer's disease to try to slow down the rate of progression of Alzheimer's disease. And what they've done is they've identified that if you make an antibody to the abnormal protein, outside of the body of the person and then inject it like a injection of immunoglobulin or like a vaccine, then you can slow down the accumulation of the abnormal protein in people who already have it, and you can decrease it if you give it much more early in the course of the disease. The use of antibodies to treat certain diseases is not new. We've heard about antitoxins for diphtheria, we've heard about anti-rabies serum. All of this goes back to the time of Pasteur in the 1800s. What is new is that we can now make such proteins specifically for chemicals that wouldn't be made in nature, like a bacteria or a virus or a fungus, but actually an abnormal protein that we might be able to construct in the laboratory, like this one, and then have the monoclonal antibody developed. And what is really going to happen is very interesting. At the meeting that we had last week, there was a description of monoclonal antibody to a chemical called calcitonin gene-related protein, that if you gave one shot of that antibody to someone who has migraine, then you were able to stop their having a migraine for 3 to 6 months. One shot, no migraine for 3 to 6 months. That would be the extreme of what this kind of technology might be able to do. What's going on right now is at the level of Alzheimer's disease, they're using different monoclonal antibodies. They're using chemistry to understand what they do and how they clean out these abnormal proteins from the brain in Alzheimer's disease. And they've identified the following. If you use a certain type of monoclonal antibody, you're able to slow the rate of progression of Alzheimer's disease. And it's advanced to the point now that they're going to be looking at asymptomatic people based on whether they have an abnormal amyloid scan. So we've advanced to that point. It will require multiple injections, and unlike the migraine story where it was one injection every 3 to 6 months, it may require weekly or monthly injections for the Alzheimer's. So where we want to go in terms of ALS is develop particular monoclonal antibodies to the SOD1 proteins, and then develop them and bring them into the clinic and test them in the clinic. The way ahead has been shown by the studies with respect to Alzheimer's disease. The extreme has been with respect to migraine, one shot every 3 to 6 months. But if we can have any suggestion that we could affect these propagated protein misfolding diseases, ALS is one of those with SOD, Creutzfeldt-Jakob disease, which led to our understanding of abnormal proteins causing neurodegenerative disease. These are diseases caused by eating the wrong food or people. In New Guinea, if you ate your neighbor and they had this disease, you could get what is called Kuru. And in Western civilization, if you eat what's called mad cow disease, then you can get what's called Creutzfeldt-Jakob disease. Parkinson's, the Lewy bodies are made by the abnormal protein alpha-synuclein. That's toxic when you test it in tissue culture, and there will be antibody studies like there is for Alzheimer's disease that will come along for Parkinson's. They're even thinking that they might have something for schizophrenia, something for type 2 diabetic neuropathy, Huntington's disease, and already they have a treatment in place for a rare disease called amyloid neuropathy. So the future is here, but it isn't available in the clinic yet. And I think what we're going to see is the development of more unique therapies In a way, it will be similar to what's going on in multiple sclerosis, which is another neurodegenerative disease, but it's an allergic autoimmune disease. And we started out with injections, monoclonal antibodies, and then we understood what those monoclonal antibodies did. And within 10 to 20 years now, we're moving towards oral agents. I think I can't say that we will see things in 5 years. I think you have to sort of look that this will be a longer development plan. Thank you for your attention, and I'll be open for any questions.
Doctor, what's the medicine that just came out recently?
I'm sorry?
The announcement came out the first quarter of May.
About Terrasemta?
Yeah.
Right.
What's your thought on it?
That was a drug which was like Nudexta. We were hoping that it would increase strength, and it did. It increased vital capacity. But they made a mistake of saying that they wanted to have an effect on the ALS-FRS scale. And they did not meet that in the 3-month treatment. So 2 out of 3, they had to, in order to get it through the FDA, they would have to make 3 out of 3. And so the company is now having to figure out what the next step is. My feeling is, and I made this recommendation already, they should just go for the 2 that were positive, go back to the FDA and say, we're not going to try to affect the ALS-FRS-R outcome. We'll just look at breathing and strength. So I think that is a drug for symptomatic therapy that we'll see trying to be developed further.
Still several years down the road, I would imagine.
Unfortunately.
Have they been doing any stem cell transplants for ALS?
Are we doing them here at Caroline's Medical Center? No.
Or anywhere?
At Emory and at University of Michigan, they have used the neurostem stem cell, which is an embryonic fetal-derived stem cell from the University of Wisconsin Y-Cell Institute. The Y-Cell Institute developed those cells and then sell them, just like the brainstorm model. And that's a company that's set up outside of Bethesda, Maryland, near NIH, and they're trying to develop stem cell therapies for ALS, spinal muscular atrophy, and stroke, and spinal cord injury as well. The bone marrow transplant, similar to brainstorm that you've heard about, that study started at Mayo Clinic earlier last year, and they had 2 deaths. We can't understand why they had 2 deaths. So it was put on hold by the Food and Drug Administration. They'll be released to go ahead because, you know, whenever something like that happens, you have to do what's called a root cause analysis, try to figure out what's wrong. It's highly unusual for a bone marrow transplant program to have deaths. In Italy, where my friend has done that kind of thing beginning about 20 years ago, she had no acute deaths. I mean, she's had nearly 36 patients treated. They're following them, seeing, compared to a historical control, how things are going. Right now, the best readout of all the stem cell therapy to date, remember the cells aren't going anywhere, is that there's no difference in survival with stem cells compared to riluzole right now. There are a number of programs in Europe that were doing the bone marrow program, but they were thought to be inappropriate business models, you know, taking money from people, not giving them the correct thing, not having good quality control. So the equivalent of the FDA has shut down such programs. And 60 Minutes, if you saw it about 2 years ago, went through a similar thing that was shut down in the United States. It was a recent company in Covington, Louisiana, looking at bone marrow, and they were shut down by the FDA because they weren't maintaining the proper controls and that type of thing. But the problem isn't so much the charlatans, in my opinion, it's the fact that we have a roadblock, biological roadblock. We have to get through that biological roadblock to see what's going on. I think by putting the stem cells into the muscle of animals and into the spinal cord at the same time, and showing that you can begin to have process extension from the cells that are in the spinal cord, that's like the first small flight by Orville Wright. We got to study that more and then figure out how to make it occur so the cells go out to the muscles and replenish the muscles.
Thank you.
On to Ms. Lucas.